we have Dr. Arjang Djamali giving us a talk. Dr. Djamali is currently the chair of the Department of Medicine at Maine Medical Center in Portland, in Maine. He earned his medical degree from Montpellier School of Medicine in France. He did his residency in internal medicine in the Wayne State University in Detroit, and a fellowship in nephrology at University of Wisconsin in Madison. Cold weather everywhere. And he joined the faculty in University of Wisconsin and rose through the ranks to the position of professor of medicine and surgery and became the head of the division of nephrology. Dr. Djamali is board certified in medicine and nephrology, and he's member of the American Society of Nephrology, the American Society of Transplantation. As a transplant nephrologist and scientist, with more than 200 manuscripts published in peer-reviewed journal, he has been considered a real national leader in the areas of antibody-mediated processes in kidney transplant outcomes. He has been widely funded by the NIH, multiple foundation, throughout the industry, throughout his career, and has been a member of the NIH, VAH, and the National Society's grant review panels. He's a member of advisory panels for the FDA and many pharmaceutical industry, and a regular invited speaker nationally and internationally. And he currently also sits on multiple planning committees for national and international meetings. Dr. Djamali holds 3 INDs and is currently an associate editor for Kidney 360, which is the most recent publication from American Society of Nephrology. This will be a really interesting talk. We're very privileged to have you, Dr. Djamali. I'm gonna go ahead and unshare my screen. The crowd will be able to ask questions now at the end of the talk.
Thank you very much, Dr. Safa. It is my distinct pleasure and privilege to be here today with you all and present on this topic of antibody-mediated rejection. Please let me know if you are seeing my slides.
Yes.
Yeah, great.
Yeah.
Outstanding. Well, you guys are the current and future leaders of transplantation and nephrology. So for me, it is not only a fun exercise, but an important one to talk to you today about this topic. I also want to thank GlomCon and thank the leaders, including Dr. Ali Pouyanmer, Dr. Qasim Safa, who kindly introduced me, and Dr. Mario Rubin, who originally invited me almost about a year ago. So without further ado, this is my disclosure slide. I am currently, related to this talk, a member of the advisory board for CareDx and also a member of the steering committee for the Imagine clinical trial for antibody-mediated rejection. My objectives for all of you, for all of us, would be to discuss and understand the definition of, the current definition of ABMR, how we diagnose it, what are the current treatment strategies, and what are some of the main limitations in both the diagnosis and treatment of AMR. I would like to start with a case that happened about 10 years ago when I was in Wisconsin. It was a 50-year-old or so gentleman, kidney transplant recipient on maintenance immunosuppression with mycophenolate and prednisone, presented with a rising serum creatinine over time, checked his antibodies and determined that he had de novo GSA of class 2 around 20,000, so high MFI levels, at least at our institution. We did a biopsy, didn't really show much interstitial inflammation, tubulitis, arteritis, but had mild glomerularitis, peritubular capillaritis, microvascular inflammation score of 2, moderate C4D staining, minimal hyalinosis, but advanced or severe transplant glomerulopathy, and some mild chronic interstitial fibrosis and tubular atrophy for an overall chronicity score of 5. we didn't really know what to do. And at that stage, the overall thought was, okay, maybe just optimize baseline immunosuppression, which is what we did. His mycophenolate, which was at 360 twice a day, was increased to full dose. And we reintroduced tacrolimus, which was originally added because it was thought that it was going to be nephrotoxic. But unfortunately, what happened is that this gentleman lost his allograft about a year after that biopsy. So what we are going to talk about today is what I call the triple aim for kidney transplantation. I don't think that anyone would argue that if we could achieve this goal, we would really achieve or reach the holy grail in transplantation. People talk about the holy grail being tolerance, but I'm not as optimistic or as ambitious. I would say if we can achieve the goal of 1 kidney transplant for life, optimal immunosuppression, that is no rejection, but of course, no infections, no cancer. So in other words, precision medicine, and no kidney allograft biopsy in a scenario where we don't have to really proceed with invasive processes, that would be a huge achievement. With that in mind, let's move forward and determine what is really antibody-mediated rejection. The terminology is quite specific, and it includes antibodies, so antibodies here, that mediate rejection. This rejection can be either direct through antigen-antibody interactions. These antigens are primarily HLA peptides that are presented on the surface of endothelial cells. So a direct pathway, activation of the endothelial cell, resulting in cell proliferation and ending in fibrosis if the repair process is not appropriate, or through an indirect pathway. The indirect pathway will require either the complement, hence the deposition of C4D as a footprint of rejection, or it will be complement independent. And this is a process in which you have peritubular capillaritis or glomerularitis through recruitment of PMNs, monocyte macrophages, or NK cells. These are all processes that require the presence of antibodies in terms of the interactions with the antigen on the surface of the endothelial cells. And as nephrologists, we know that endothelial cells are primarily present on the surface of endothelial cells. Endothelial cells are primarily present in the glomeruli for the glomerular capillary loops and in peritubular capillaries. Now, let's put that in context. How bad is AMR, or antibody-mediated rejection? I will just present that in a couple of slides. Number one, from a prevalence and incidence perspective, this is one of the studies that has been largely quoted, multiple centers looking at 315 kidney transplant biopsies based on indication that determine, just profiling the changes with time, looking at it. You can see that in the early days after transplant, most of these biopsies were really not finding any major abnormalities, but with time, the primary finding was antibody-mediated rejection associated with disease recurrence, and then tubular atrophy, and of course, mixed rejection. So in the lifespan of a kidney transplant, it is a common finding. We looked at it recently from a different perspective. We looked at 330 cases of graft failure and patients that had undergone a kidney transplant biopsy within a year prior to that. And looking at that, we determined the same thing, in that the most common causes of graft failure, associated with graft failure, I should say, with time, were rejection and transplant glomerulopathy, or in other words, chronic antibody-mediated rejection. So it is common, it's associated with graft failure. Then you could say, okay, well, what's the big deal? Graft failure, of course, we don't want graft failure, but this is one of the Great slides that I have always represented from Bruce Kaplan and Ulf Meyer-Krisch's study in 2002. This is what happens in terms of adjusted patient survival after graft failure. So once patients return to dialysis, compared to those that remain with a functional transplant, patient survival adjusted for a bunch of standard baseline characteristics is significantly lower. So this brings me back to the original discussion of one kidney for life and how we want to preserve every mil per minute of that GFR to avoid dialysis or retransplantation. Now, let's move forward towards the current means for the diagnosis of antibody-mediated rejection. The gold standard has not really changed. It's kidney pathology, and the Banff diagnostic criteria are based on that. This is the most recent report that was published a year and a half ago. Banff 2019 is going to talk to us about those variables that I was showing to you earlier on, those molecular and cellular pathways that result in antibody-mediated rejection. What Banff recognizes as the definition of active antibody-mediated rejection is when you have all three criteria present. The first criterion is evidence of acute tissue injury. The second evidence is a criteria requiring evidence of antibody-antigen interactions. And the third one is evidence of circulating DSA. So exactly what I showed you on that first figure. The acute changes have to be an evidence of microvascular inflammation, so glomerularitis or peritubular capillaritis, can be intimal or transmural arteritis, so a V score. Acute TMA, of course, in the absence of other causes like CNI toxicity or complement pathway abnormalities, and or acute tubular injury in the absence of any other apparent cause. What about evidence of current or recent antigen-antibody interaction with a vascular endothelium? It could be just a linear C4D staining in the peritubular capillaries, not glomerular, but peritubular capillaries. It could be moderate microcirculation inflammation. That's some score of 2 or higher, that in this context is strongly suggestive of antibody-mediated rejection. If there is coexistence of T-cell mediated rejection, then the G score has to be higher because none of these scores alone is specific for antibody-mediated rejection. And finally, more recently included is evidence of gene expression or transcripts or classifiers for antibody-mediated rejection. In terms of circulating DSA, of course, that's a requirement. Now, you may not be able to detect them. In some cases, that can be replaced by linear C4D staining as an evidence of antigen-antibody interaction or a footprint of that interaction. Or you may want to look for non-HLA DSA or antibodies that are not specifically directed to HLA antigens. These are a bit more challenging to detect, and we can talk about it at a later stage. What about chronic AMR? And this is actually the situation that's much more prevalent, and that is the more common cause of graft failure. In fact, there is no real difference. The definition of chronic active ABMR is exactly the same thing as active ABMR, except for the first criterion, and that is that acute changes here are replaced by chronic changes, and specifically transplant glomerulopathy or a CG score that has to be positive. Other than that, everything else is pretty much the same. So moving forward, I'm going to show you some pictures because this is GlomCon of a glomerulus and what really is glomerularitis and glomerular injury in antibody-mediated rejection. This is a picture that I borrowed from this AJT paper from Mark Haas, and it is showing you evidence of glomerularitis. This is a PAS staining. You see clearly evidence of mononuclear cells in the capillary loops here, 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 etc. So these are not supposed to be there. In some instances, the capillary loops are actually almost obstructed. You can see it here. And it is associated with peritubular capillaritis. And you see that here. These are cross sections of proximal tubules and PAS stain, as you can see clearly. And these are capillary loops that are normally in between them, are not inhabited by invading cells like this. And these mononuclear cells are all either NK cells, T cells, or monocytes that are responsible for peritubular capillaritis. What about transplant glomerulopathy or TG? This is a silver stain of a patient of a biopsy that shows transplant glomerulopathy. The silver stain here is showing you the duplication of the glomerular basement membrane. You see it here, you see it here, you see it here, you see it pretty much everywhere. But also here you see evidence of active glomerulitis here, here, and and elsewhere, like here. So you have segmental double contours for the glomerular basement membrane associated with glomerulitis. Typical diagnosis of transplant glomerulopathy. On electron microscopy, this can be seen also with these three characteristics that are swelling of the endothelium, electron lucent layering here of the basement membrane, and of course the overall multi-layering. So transplant glomerulopathy is, as I was saying, the very early sign of chronic active antibody-mediated rejection, as you are seeing here. And it can be mild, moderate, or severe. Severe cases are associated with worse outcomes. Now, what are the limitations of renal pathology? I won't have to convince you that this is an invasive procedure. If we didn't have to, I'm sure none of us would like to do a kidney biopsy. But on top of that, there is an issue with specificity for antibody-mediated rejection. As I was telling you, there is not a single marker or finding that is consistent with the definition of a BMR. You have to have those three criteria. Then there is inter and intra-observer variability, and this is something that has led to the development of some of the tools that I will be talking about, including gene expression profiles that are more objective. And finally, there is a reproducibility issue. As you know, the biopsy is not always going to be reproducible. There is a sampling error process and a time dependability of the findings that can be challenging. This is a paper that we published not that long ago. We looked at our complication rates in almost 4,000 kidney transplant biopsies in Wisconsin. And you can argue that the complication rates were not huge, but 2%, so 1.8% of our patients had some sort of a complication. There were no deaths, but life-threatening 0.19, that is patient having to go to the operating room for evacuation of the hematoma. So again, we use this, to obtain consents from patients. We would like to avoid the 1.8% complication rates, but if we have to do it because that's the gold standard. The current changes in the transplant community have led, because of some of the things that I was talking about, to the development of new biomarkers for antibody-mediated rejection. And I could talk about this for hours and hours, but I'm going to focus on 3 areas and hopefully deliver you the big message. One is gene expression profiles, one is donor-derived cell-free DNA, and one is artificial intelligence or IBOX prediction score. We summarized these in a recent review paper with one of our back then fellows, now faculty, Kurt Swanson. And if you want, you're more than welcome to have a look at this paper that has a nice summary of it. But let's start with the gene expression profiling, and let's start with the kidney. As you probably all know, Phil Halloran here on the left was one of the pioneers that repeatedly mentioned what I was saying about how invasive a biopsy is, the observer variability, the intra-observer variability, and the importance of gene pressure, of gene or transcript analysis. He developed MMDX, which is the molecular microscope diagnostic tool based on Affymetrix, recently approved by the CMS for reimbursement, which represents a panel of genes that are involved in T-cell mediated rejection, antibody-mediated rejection, and other injury repair pathways. So this has now been validated and is commercially available. It is not the only one, though. There are many other Affymetrix or microarray analysis analytical tools that are available. There's a nanostring platform, and there is a group by Banff. It's called the Molecular Diagnostic Working Group, led by Michael Mengel here. It's developing a panel of 700 genes called the B-HOT panel. And these genes are involved, as you can see here, again, in multiple cellular and molecular pathways that result in allograft injury that can be specific for organs, including a kidney allograft. This is a pathway that's under development. It's being validated throughout different platforms, and it is another ongoing process that is promising. Here I have a representative of studies that have examined gene expression panels in the blood. So it is not as invasive as the kidney. And at the same time, the idea is the same. Most noteworthy of these are K-sort and TrueGraph gene expression profiles that have recently again been approved by CMS for reimbursement. These include a panel of genes that can tell you if the immune system is activated, if there is consistency with rejection or not, and can be helpful in terms of complementing the information for the diagnosis of rejection. What about really the least invasive of all these, a urine test, right? We're all nephrologists, and that's what we really like to do, right? Looking at the urine or analyzing it in many different ways. Here is a table that I am sharing with you. I modified it a bit from Dr. Sawinski's recent presentation at the AST Consensus Conference for Biomarkers. And it is showing you some of the sensitivities and specificities of various assays that have been developed in general in the scientific field, except for the last one here at the very bottom. This has crossed the scientific validation steps and is now approved by CMS. And I think that it will soon become available on the market to be utilized for the diagnosis of rejection. As you can see, high sensitivity, high specificity, and an area under the curve that's really exciting. Now, please bear in mind that these are in general studies of at most 300 patients. These are not thousands and thousands of patients. None of these are studies that have been validated prospectively using interventional or randomized studies that really bring the utility, the clinical utility of these tests to to the market. But I thought that it was my responsibility to share some of this information with you, because the topic is practical aspects of ABMR. These are going to come to you, and if not already, knocking on your door, and let's do this, let's do that. And as you will see, the cost of these tests is quite significant. So you are going to have to be very thoughtful and cautious in selecting the tests that you use, and determining what you are going to do with the result of that test. The next family of tests are called donor-derived cell-free DNA assays. And here I'm representing a figure from AlloSure. In essence, the idea is based on the fact that the donor kidney under stress is going to have some cell death. That's understandable. Tubular cells, endothelial cells, they can die, and as a result, they release DNA fragments from the donor. These are our own or the recipient's DNA fragments. Then under injury, you're going to have more donor-derived cell-free DNA that can be measured using SNPs, and as a percentage of total can be presented, and then you can grade the level of injury. Now, a large number of studies have been now published. I mean, everything is relative. I say large, but this is again the sample that I'm representing for you here. Most of these studies include couple 300. The one that includes thousands of them is the Admiral study, and that is a multi-center study that looked at the sensitivity, positive, negative predictive value of donor-derived cell-free DNA for the diagnosis of rejection. In general, what I will say is that the donor-derived cell-free DNA has a high negative predictive value for antibody-mediated rejection, because the topic of this test is, of this discussion is antibody-mediated rejection. So just like the D-dimer that we talk about and the risk of PE, a low or normal donor-derived cell-free DNA is really unlikely to be associated with antibody-mediated rejection. But again, having said this, there's plenty more to come, and more studies need to be published in terms of interventions. That's the gradation I was talking about in terms of the AlloSure risk stratification. For instance, if the level is lower than 0.5, there's a high likelihood that there's no active injury. So that's a negative predictive value. And then as the donor-derived cell-free levels increase in terms of percentages, then your risk of injury increases, which is not surprising. Last biomarker, and I quote biomarker, is actually based on artificial intelligence, and it's the IBOX score. Now you can ask me, why do you put IBOX in antibody-mediated rejection? The reason is that it includes some of the histopathological criteria that are specific to antibody-mediated rejection. The IBOX is a tool that includes 8 variables. These variables are functional, including time from transplant, estimated GFR and proteinuria, so kidney function and time from transplant, and then pathology. So some of it is non-specific, like interstitial fibrosis, tubular atrophy, but some of it, as you see here, is more linked with antibody-mediated rejection, like microcirculation inflammation and transplant glomerulopathy. There's, of course, also a component of T-cell mediated rejection here, interstitial inflammation and tubulitis. And finally, the strength or presence or absence of antibody, of donor-specific antibodies. Why is this tool important? Why has it been validated? Yes, it has been validated across several countries and continents. It is held its value in terms of a C index or a prediction of graft failure. So with 81% certitude or accuracy, it can predict graft failure with a confidence interval that is quite tight. So this is really promising. IBOX, I think it's really promising because it can also lead to the design of prospective clinical trials, potentially as a biomarker or a surrogate marker of graft failure. How can I summarize in 8 bullets the advantages and limitations of these new biomarkers of antibody-mediated rejection? I say advantages are obvious, non-invasive. They may enhance diagnosis accuracy, and they can also offer a possibility of multimodality testing. IBOX, as I said, is promising for clinical trial design, which is a significant issue in transplantation. But the limitations are time dependency. Depending on the time after transplant, different molecules, different biomarkers can have different meanings. They have not been validated in prospective randomized trials, interventional. This is really key because, again, I think it's premature to use all of these tests in this growing field. The clinical utility is unknown as well. We don't know the impact on long-term outcome. You don't know what to do with the results of these tests. Should you treat, should you not treat, should you biopsy, should you not biopsy, and really what is the exact value? And finally, the cost. They are prohibitive. I mean, they could be prohibitive. They're like, many of these tests are in $2,000 to $3,000. So again, before writing for these or prescribing these tests, I think we have to be thoughtful. What are some of the treatment options for antibody-mediated rejection? Well, for that, I want to get back to this cartoon that I like, and I originally designed it when I was talking to the fellows on the floor when we were rounding, and I really like to grow it and talk about it more. When you think about the downstream events, that is the endothelial cell and the interactions with antibodies, it totally makes sense that the treatment of antibody-mediated rejection would require the elimination of these. And the elimination of these can happen either through plasma exchange, right? Or some of the newer molecules that are available, like the endopeptidase molecules, and we will talk about that. It also makes sense to inhibit complement. We have heard of eculizumab. This is the C5, the N-terminal pathway, or some of the newer, some of the upstream molecules. I will tell you that these trials have in general been negative in the field of antibody-mediated rejection until now. Plasmapheresis remains one of the standard of care tools for the treatment. Then when you go upstream, you have plasma cells, right? Well, you have a large number of, a growing number of molecules like proteasome inhibitors, bortezomib, carfilzomib, ixazomib, and so forth. You have IL6 blocking agents. We'll talk about it, tocilizumab, clazakizumab, and other agents that have been used in the field of multiple myeloma or Waldenstrom. They have potential. What about further upstream? B-cell inhibiting agents. Of course, you have heard of rituximab and some of the newer molecules, maybe with greater affinity. What about inhibiting APRIL and BAFF, like it's been done in the field of lupus nephritis or in the field of rheumatoid arthritis in general? Finally, we know that T cells are upstream from B cells, and there are many people that treat severe antibody-mediated rejection with thymoglobulin and co-stimulation blockade with belatacept or calcineurin inhibitors. IVIG has the pleiotropic impact on all of these at all levels in this pathway. And we could talk about this for a large amount of time, but overall, I would say that all the studies here have been unsuccessful to convince people and the community that there is one effective treatment. Let's talk about that. And let's keep in mind another thing, in that if you decided to treat plasma cells, you have to remember that there is going to be an impact not only downstream, but also upstream. If you treat the B cells, if you depleted B cells, you have to remember that some of these B cells have a negative impact on T cells, and removing them can release the T cells to grow and become active. So there is not just a unidirectional process here. It goes both ways, and you have to consider the negative feedback. This is the most recent FDA public workshop result. I had the privilege to be there and talked about this, and the result has not really changed. Currently, there are no FDA approved treatments for acute or chronic antibody-mediated rejection. Having said that, similar to desensitization protocols, plasmapheresis, high-dose IVIG constitute the standard of care with some add-ons per center preference. The FDA acknowledges that the treatment of acute and chronic rejection constitutes an important medical need. So what do we have? We have expert guidelines, consensus guidelines. This is KDIGO. KDIGO suggests treating antibody-mediated rejection with or without steroids, combining one of these agents that I was talking about: plasma exchange, IVIG, anti-CD20 antibodies, and lymphocyte depleting antibodies such as thymoglobulin. What about the Transplant Society? This is a more recent manuscript published by Gary Shinstock and the team. The result is the exact same. I'm going to split it a bit for you here. They talk about early rejection. Here is defined in the first 30 days, and late rejection after 30 days. For the early rejection, primarily associated with pre-existing DSA, if you have active rejection, standard of care is plasmapheresis, IVIG, and steroids. You see, it's pretty much consistent. But the level of evidence is 1C at best. They say to consider adjunctive therapy with complement inhibitors, rituximab, splenectomy, depending on the context. But as soon as we talk about de novo DSA or chronic changes, see that the consensus is just optimize baseline immunosuppression. They could not really make a strong recommendation to any other standard of care. Optimize baseline immunosuppression. But consider in adjunctive therapy, these that you see on the right side. So we are really not doing great in terms of strong evidence for the treatment of rejection. In terms of up to date, this is another expert panel that includes myself, and this is a bit what we do recommend. Early versus late. Early, we recommend pulse steroids, plasmapheresis, and IVIG, and rituximab, and I will show you why. And for late, we don't recommend the use of plasmapheresis because of cost considerations, practicality, evidence, as I was saying, and also the challenges to implement. So the point is, these are all opinion-based and based on observational studies. I want over like 3 slides show you the natural history of these protocols that we developed at UW over the past 15 years. This was our first observation. Probably to date, the largest case series of patients with chronic active AMR, 120 patients. This was an observational study, of course. We determined that those that just got really no additional therapy except for adjusting baseline immunosuppression had a half-life of 12 months after diagnosis. Those that received steroids, IVIG alone or in combination had a better survival rate, and those that had rituximab and or thymo had a better survival rate. Having said that, again, this was observational, and after this, but based on this, we decided that all of our patients with active disease were going to receive pulse steroids, IVIG, and rituximab. In a follow-up study, we demonstrated that compared to those that are not being treated or just receiving the standard of care without rituximab, the half-life of those that receive rituximab is significantly greater. Now, again, I am saying that this is the UW experience, and many other centers do not use rituximab, but for us, it has been a successful story. This is a paper that is being reviewed as we speak, and I'm reporting here to you the 3-month findings on protocol biopsies. So first, patients that get antibody-mediated rejection, 3 months later, they get a follow-up biopsy. This is in blue, those that get steroids IVIG, in orange, those that get rituximab on top of that. This is the GFR response. That means that 27% had a decline in GFR within 10% of their baseline. When they got rituximab was higher. Proteinuria response, that is more than 25% reduction in proteinuria, in addition, of course, to the standard of care with ACE inhibition, RAS blockade if needed. This is, for me, probably the most significant finding, that microvascular inflammation doesn't really improve much. For only 20% of patients that receive steroids, IVIG, rituximab, end up having a microvascular inflammation of 0 after 3 months of therapy. In terms of DSA response, that's a decline of 50% or more. This is what you see at 3 months. Now, what about some of the emerging therapies? And I think this is the most fun part for us to discuss in terms of treatment options. One is the use of imlifidase. Imlifidase, or IDIS, is this a protease inhibitor that cleaves IgG at the hinge level and makes it totally, destroys it. It's like plasmapheresis, but without removing the circulating antibodies, right? This was a paper by Stan Jordan and his group for desensitization. So at the time of transplant, you can see here the strength of these antibodies that got totally destroyed by IDs after 1 or 2 doses. So huge potential. As a result, there is now a phase 2 randomized controlled trial, 1-to-2 distribution. The standard of care is going to be plasmapheresis, IVIG, and rituximab, comparing that to imlifidase, IVIG, and rituximab for the treatment of antibody-mediated rejection after transplant. So not desensitization, but treatment of AMR. And the primary endpoint is DSA decline after 5 days, and secondary endpoints, of course, are safety and efficacy. So the study is recruiting, and I encourage all of you that are participating in this trial to do your best to help with the recruitment. A few words about IL6 blockade before we finish. IL6 blockade is now the area we are investigating for the treatment of antibody-mediated rejection. This is the bone marrow niche. This is a stromal cell. This is a plasma cell that you see here. IL6 and its receptor can have a significant impact on plasma cell activity and production of antibodies from the bone marrow. The overall idea, the concept was coined here by Dr. Stan Jordan again and his team when they used tocilizumab, an anti-IL6 receptor blocking agent, in patients that had really not responded well to that cocktail I was talking about before. So that was IVIG, steroids, and rituximab. So those patients, in addition to those two therapies, received tocilizumab. And Dr. Jordan's team showed that DSA in those patients continued to decline, and kidney function and graft survival stabilized to about 80% at 6 years. So that was really an original proof of concept that led to the development of a trial that's a randomized controlled trial, small size, just published in JASN this past year in Austria using clazakizumab. George Bomig and his team looked at patients, 10 in each group, that received clazakizumab versus standard of care or placebo, and determined that patients that received claza had a molecular resolution at 1 year based on molecular diagnostics of around 40%. C4D disappeared in about a third of them, and morphologic ABMR disappeared in about 22% of them. So overall, the drug was well tolerated. Of course, there were some infections, some diverticulitis, but overall, the safety signal was positive. As a result, the largest randomized controlled clinical trial in the field of kidney transplantation for the treatment of any rejection has been designed. And this is the IMAGINE clinical trial. IMAGINE clinical trial is a clinical trial for safety and efficacy of clazakizumab, IL6 blocking agent, for the treatment of chronic active ABMR. Patients with chronic active ABMR are going to be randomized to clazakizumab versus placebo. The study is supposed to be completed in 2028. A multi-center study, more than 80 centers are involved. 350 patients are to be enrolled, and so far about 100 have been enrolled. This, for me, is one of the greatest contributions of the field to the long-term outcomes of kidney transplantation. And I feel that if, again, any of your centers is involved in enrolling patients and in retaining patients for this study, that's a privilege. You can really contribute to the future of the field. Summary and future directions. I think that there's no doubt that you all agree, no FDA approved treatment for antibody-mediated rejection. This is primarily because we don't have high quality evidence, except for the last couple that I was mentioning. So we have to wait for those. For now, most practices are based on opinion and focused on antibody removal and cell depletion therapy. And the ongoing studies for IL6 blockade and anti-hinge therapy are going to be really helpful to a better understanding of the future. This is our goal. Let's work together to get this to this place. I think that the younger ones amongst you have a greater likelihood to get to this point. And on that note, I am most grateful for your time, attention, and I'll be delighted to answer any questions. Thank you.
Well, thank you so much, Dr. Djamali. This was phenomenal. It was really a nice tour de force that had diagnostics, therapeutics, and a lot of history all packed in 50 minutes. And I'm glad we have some time for questions. If I may start, just where you ended about the IMAGINE trial, which is we are a center participating in the trial, and we're all looking forward for those results. Do you think something similar to the IMAGINE trial, something multi-center, 5 years with the solid outcomes, could be done for the biomarkers? Just because the biomarker studies, it's kind of really interesting, very cool science, but sort of fragmented between centers, between the numbers. The validation has been a little bit behind the test. So how about a 5 years trial, multi-center, 1,000 of patients, and have solid outcomes, whether the use of biomarkers is useful or not useful?
What a great question, Safa, Dr. Safa. This is absolutely needed. I think to validate what you just said, we just finished the AST consensus conference on biomarkers, and thought leaders were attending, and we all said exactly what you just said, in that we need a well-designed long-term interventional trial. There are two issues. One, of course, is to operate this, and one is to fund it. I will give you some hope in that Dr. Alex Lupi from France has designed and hopefully will start the trial in Europe. They have received European Union funding. This is more than $80 million of cost, as you can imagine, but it's beautiful to see that it can happen. So they are going to do it. I don't really know exactly how many biomarkers are going to be evaluated, but you're absolutely right. If we could convince the industry to help us fund, a trial like this for the US and for North America, that would be absolutely great, because we have the patients, we can contribute to it, but we just need the backing. Maybe we need, industry and NIH and foundation funding support, but so complicated here in the US.
Thank you for that. I will just try to ask a couple of questions from the chat box, and then we can go to the attendees who raised their hands. We had a question, interesting question, someone who has ABMR and a history of Kaposi sarcoma. A classic idea of being stuck between a rock and a hard place. Would you do retox for these folks? Would you do plaques, or you would stay put?
That is another great question. Kaposi sarcoma and antibody-mediated rejection. And, we see this frequently. We see patients with ABMR and malignancy, patients with ABMR and infections like CMV, BK, or fungal infections. I think at this stage, what is really most important for all of us is to think more about the patient than the kidney. So I know as nephrologists it can hurt, but that's what we need to do always, right? We have to think doing the right thing for the Kaposi sarcoma and then get back to the kidney, hoping that the kidney will have lasted during that period.
Great, great. Dr. El-Jurdi, one of our fellows extraordinaire, actually asked, how do you time the rituximab around the plaques? Do you freeze the whole course and you do the retox, or do you do it between sessions? Any thoughts on that?
Yes, absolutely. That's another very good question. There is evidence that plasmapheresis, if done within 24 hours of any immunoglobulin therapy, would remove up to 30% of it. So it can be thymo, it can be rituximab, it can be anything else. So what we do is we first do the 3 consecutive plasma exchange sessions and spaced by 1 day in between, and then we administer rituximab. I feel that rituximab can be given after, because the main thing you want to do, the time-dependent variable here is the pre-existing DSA. You want to remove them and then to hit the bone marrow or the lymph nodes to avoid rebound or the generation of new ones.
Got it. Thank you so much. One more questions from the chat box before we move to the live questions. What if you find incidental donor-specific antibodies without evidence of C4D on the biopsy, without evidence of rejection on the biopsy? What would you do?
That's another great question. We actually published this in Kidney International KI reports 2 years ago. In our center, hundreds of patients, when we looked at DSA, exactly this case, patients that have DSA but no rejection, we don't do anything. We just monitor them. What we do is not to decrease their immunosuppression. And long-term, we have seen that these patients are doing just as fine. So DSA, in the absence of rejection, at least in our hands, is not really associated with bad outcomes. There's a bit of an inconsistency. The Mayo group showed that half of those patients in follow-up have rejection in follow-up, but graft survival has not really changed. So my advice is, if you have DSA but no rejection, don't reduce immunosuppression, or at least optimize your baseline immunosuppression.
Exactly. Great, thank you. Let me have Dr. Mario Rubin has a question.
Thank you, Kasim. So Arjang, fantastic presentation. Thank you. So I read a recent report that the combined use of the genetic panel, TrueGraph, and donor-derived cell-free DNA is better than either one alone. And I wonder if you can comment on that. And the other question is, how do you propose to ensure complete treatment of the antibody-mediated rejection process? Do you think that a kidney biopsy should be repeated, or do you think that the molecular biomarkers that you discuss are enough?
Thank you very much for these two outstanding questions. And number one has to do with multimodality, and I will address that first. There are two papers now that are out looking at multimodality. That is the Association of Donor-Derived Cell-Free DNA and the genomic approach. And one of them was published in CJSON, I think by John Friedewald's group, including TrueGraph, absolutely. And the other one was by Dr. Akalin and colleagues in Kidney 360, looking at AlloSure and AlloMap. The concept is to combine molecular signatures of allograft injury that are sensitive to injury, but not really specific to rejection, and additional biomarkers that really look at your immune system. Like, is the immune system active? Is the T cell, component or gene transcripts on the active side, or B cell on the active side, or not? I think this is going to be the future of transplantation, but not at the current cost. If this was the cost of, like serum creatinine, yeah, absolutely. But if it is going to cost us like $5,000 a shot, a pop, and a biopsy is about $1,000, a kidney, a nephrology consult is about what, like $300 or something. So I think we are not in a good area right now for that. The second question was follow-up. Again, there are a couple of studies that were published. Again, one in Kidney 360 looking at AlloSure response to treatment after rejection, suggesting that cell-free DNA levels decrease after treatment, and you may not have to do a follow-up biopsy. I will even go back and further upstream, and I'm just questioning what is the right time frame for doing a biopsy after you have started treatment of rejection. Is it 1 month? We have done it. I think it's too early. Is it 3 months? We have been doing it, and now I think it's too early. Is it 6 months or 12 months? I really don't know the time, because what really happens, Mario, is that the response in the kidney is delayed compared to the intervention or treatment. We don't see it right away. So it can guide a bit in understanding, are we on the right track? Is it getting better or is it getting worse? But in terms of it being an endpoint, I think it's premature. I don't know the right timing. And we do about 700 biopsies a year in Madison, as you know.
That's great. Dr. Randhawa has a question.
Yes, Dr. Djamali, I also enjoyed your very comprehensive talk. I had a comment about, categorizing treatment depending on whether the ABMR is acute or chronic. And the point I want to make is that this acute chronic distinction is a very gray area, and you cannot get a good sense for what the patient has just by reading the biopsy report. For example, you can call an antibody rejection chronic when there is only mild fibrosis and just a few capillary loops are duplicated. And if that's not communicated to the treating physicians, they will say, oh, this is chronic, we shouldn't treat it. So it can sometimes lead to miscommunications. On the other hand, you can have a chronic ABMR where again, the CG score might be 1, but the fibrosis might be severe. So even though it might look like a low score, the case may not be worth treating. So I would recommend that in every such case, the pathologist and the nephrologist, they get together, look at the biopsy as a whole in a holistic way, correlate it with the clinical picture, and then determine the treatment, just not by a binary.
Yes, can you hear me?
Yeah.
Okay, I'm sorry. I don't know if you could hear me. I cannot agree anymore with you. This is fantastic, because we as nephrologists, see the functional part of it, and you as pathologists see really the essence of it in the kidney, and it's only combining the two pieces of information that can help the patient in terms of interventions. Acuity or the changes in kidney function they don't reflect always what we see in pathology. You're absolutely right, and vice versa. So we need to communicate better, and ideally look at the biopsies together and make the decision together. Totally agree.
That's great, great. Again, I encourage the audience to go to the consensus guidelines you cited in the talk, Dr. Djamali, in the published in Transplantation, which is very insightful, and I think it helps a lot of clinicians to either be aggressive with treating the antibody-mediated rejection, or simply just make the patients take their own medications or optimize the drug levels. On that note, we are after the hour. We have a lot of questions. We probably broke a record with more than 200 participants, Dr. Djamali. We really are grateful for your time on a Sunday, and we look forward for more talks in the future. And I want to thank the audience and the participants for taking the time on a Sunday to join us. And we see you again for Transplant Series next month.
Thank you very much, Kasim. Thank you, Ghulam Khan. Thank you, everyone, for all the great questions. And please tweet, direct message me, or email me if you have questions. I'm sorry if we didn't have enough time to address all the questions. My privilege and pleasure seeing you, and wishing you all a nice rest of your Sunday.
Thank you so much.